Thanks, everyone, and welcome back to the ACIP meeting. We'd like to convene, and this session we are focused currently on pregnancy safety and updates on COVID-19 and pregnancy. I'm going to turn it over to Dr. Christine Olson first from the CDC.
Okay, thank you, Dr. Lee. Can you hear me okay?
Yes, we can. Thank you.
Okay, great. Thank you. Good afternoon. In this section of today's presentation, we'll be covering updates on results from the VSafe COVID-19 Vaccine Pregnancy Registry, one of the vaccine safety monitoring systems for COVID-19 vaccination during pregnancy. Next slide, please. And next slide, please. This slide provides an overview of the enrollment process for participants in the VSafe Vaccine Safety Pregnancy Registry. People who use the VSafe after vaccination health checker indicate if they are pregnant at the time they receive vaccine or if they become pregnant after vaccination at later check-in points. They are screened for eligibility for the pregnancy registry based on whether they were either pregnant at the time of vaccination or were vaccinated in the periconceptional period, defined as the 30 days before the first day of the last menstrual period before the pregnancy. Eligible individuals are then consented for pregnancy registry enrollment and are interviewed at designated time periods. Next slide, please. The active follow-up of pregnancy registry participants includes interviews during each trimester after they have enrolled, during the postpartum period, and during early infancy. Not all participants will be interviewed during all trimesters of pregnancy, but they may enter the registry at any point in this continuum if they meet eligibility criteria. Next slide. This is the current distribution of the 5,096 enrolled registry participants by vaccine type. You can see that most received one of the two mRNA vaccines and relatively few received the J&J vaccine. Next slide. Here we see the timing of receipt of the COVID vaccine, which made the participant eligible for the pregnancy registry. There is distribution of vaccination across all pregnancy time periods. About 5% of participants were vaccinated in the periconceptional period, 28% were vaccinated in the first trimester, and about 2/3 of participants were not vaccinated until the second or third trimesters. Next slide, please. This graphic shows the expected month of participants' delivery by the timing of their first dose of COVID-19 vaccine during periconception or pregnancy. Looking just at the more than 1,400 women who received vaccination in the first trimester or periconception period, shown here in the green and blue series of bars, by the end of September, about 75% will have reached their estimated dates of delivery. These participants will have postpartum follow-up interviews typically conducted between 4 and 8 weeks after delivery, and infant follow-up after infants have reached 3 months of age. Therefore, completed infant follow-up interviews for the majority of these pregnancies are not expected until November through January. Next slide, please. The shaded boxes added to this graphic indicate the interview follow-up windows for participants with estimated delivery dates in May 2021 and later, with the pink shading indicating participants who have not yet reached their expected due date. Most of these participants received their first COVID vaccination during early pregnancy before the second trimester. Next slide. This slide depicts the characteristics of the enrolled pregnancy registry participants. These demographics largely reflect the people who were initially prioritized for vaccination when vaccines first became available, as well as those who chose to enroll in VSafe following vaccination. On the left, you'll see the age distribution, with most participants in the 25 to 35-year-old category, and a very low proportion of participants under 25 years of age. For reference, in the United States, over 20% of all live births are to women under 25 years old. Racial and ethnic distribution is on the right and is predominantly non-Hispanic white. Over time, those enrolling in VSafe have become more racially and ethnically diverse. Next slide, please. The pregnancy registry participant's occupation, derived from the question asking about vaccination priority groups, is depicted here. The majority of those who received the mRNA vaccines identified as healthcare personnel, while that was the least represented group among those who received the J&J vaccine. There are several reasons likely contributing to this, including that much of the initial vaccination of healthcare personnel occurred before the J&J vaccine received its emergency use authorization, and that the J&J vaccine's less stringent cold chain requirements made it more likely to be used outside of large healthcare settings. Next slide, please. Next, I'll discuss a recent publication from the VSafe Pregnancy Registry, where our analysis focused on early pregnancy losses. Next slide. Our objective in this analysis was to assess, among the registry participants, the cumulative risk of a spontaneous abortion, or SAB, a pregnancy loss occurring at less than 20 weeks gestation. We included 2,456 pregnant people who were enrolled in the VSafe registry and had received at least one dose of an mRNA COVID-19 vaccine carried conceptually or during pregnancy prior to 20 weeks of gestation and had not had a pregnancy loss before 6 weeks of gestation. We used life table methods to examine the cumulative SAB risk by gestational week in this cohort. Recipients of the J&J vaccine were not included in this analysis because, as noted earlier, only about 5% of registry participants received that vaccine. Next slide, please. Our results showed an unadjusted cumulative risk of SAB after mRNA COVID-19 vaccination of 14.1%. Because most of our registry participants are over 30 and therefore slightly older than the general U.S. pregnant population, we age standardized using a reference population study on the risk of SAB according to maternal age groups and found a slightly lower risk of SAB of 12.8%. As expected, we found the cumulative risk of SAB increased with maternal age. These risk estimates fall within published baseline estimates of SAB of 11 to 22% and provide additional evidence that mRNA COVID-19 vaccines in pregnancy are not associated with SABs. Next slide, please. We also conducted a sensitivity analysis of the 65 participants who met inclusion criteria for this study, but whom we were unable to reach for second trimester follow-up and thus unable to ascertain pregnancy status as of 20 weeks gestation. Under the extreme assumption that all 65 of these individuals had had an SAB, the cumulative risk of SAB was 18.8% before and 18.5% after age standardization. This slide demonstrates the weekly cumulative risk for SAB by gestational week for two published historical cohorts representing the lower and upper ranges of SAB risk represented by the blue and orange lines, respectively. As you can see, our results for both our primary analysis, the gray line here, and our sensitivity analysis, the yellow line, fall within the bounds of these two historical cohorts representing the expected risk range. Next slide, please. Next slide. Thank you. I'd next like to describe our results from pregnancies in the registry that have delivered and on which we have preliminary information based on participants' self-reported data. Next slide. Returning to this graphic representation of the estimated months of delivery of our registry participants, I'd like to focus your attention on the blue outlined area, which represents the months of delivery of the participants we'll be talking about in the next few slides. Again, for reference, the participants who received vaccine in the earlier stages of their pregnancies are represented by the blue and green bars, and those who received vaccine in the second and third trimesters of pregnancy are shown in the red and yellow bars, respectively. Next slide. We'll be focusing on the results we have for 1,613 pregnancies. We began with the 5,096 enrolled participants and limited our analysis to those who had an estimated date of delivery, or EDD, before May 15, 2021. This was done to allow enough time for postpartum interviews to be conducted in the typical time frame after delivery and data to be cleaned, reviewed, and analyzed. Among this group, we have approximately 500 who are still pending follow-up and 63 who have been determined to be lost to follow-up. The resulting 1,613 pregnancies produced 1,634 live-born infants, 42 of whom were the results of twin gestations. 70% of this participant cohort received COVID-19 vaccine in the third trimester and 30% in the second trimester. In the lower right-hand corner of this slide, we've included information about the participants in the registry who received vaccine earlier than the second trimester of pregnancy. Currently, this includes 1,428 participants. The pregnancies and follow-up are ongoing, and therefore data are incomplete at this time. However, the outcomes of these pregnancies will be included in future reports. Next slide, please. Here we have listed 4 key infant outcomes of interest: preterm birth, small for gestational age, admission to the neonatal intensive care unit or NICU after birth, and neonatal or infant death. You can see the proportions of these outcomes for these infants in the middle column of the table and the corresponding background rates of these outcomes in the U.S. population of live births listed for reference in the right-hand column. The proportions of these outcomes in this birth cohort are consistent with or below the reference background rates. Next slide, please. Next, we'll turn our focus to registry participant-reported birth defects. To provide some context, most birth defects arise in the first trimester. However, at this time, we only have sufficient data to report on birth defects among participants who were vaccinated in the second and third trimesters. As we've shown earlier, pregnancies among participants vaccinated in the first trimester are either still ongoing or have not yet had ample time for scheduled follow-up interviews and data review. We plan to present that data in the future as it becomes available. Data in the registry are self-reported by participants during the postpartum interview. Participants responded to the question, was your baby diagnosed with a birth defect? Reported birth defects were reviewed by birth defects experts to assess whether they met inclusion criteria and were then categorized. Birth defects were defined as a structural abnormality, chromosomal anomaly, or genetic syndrome. Next slide. The types of birth defects reported following vaccinations in the second and third trimesters are consistent with what we would expect to see based on population-based birth defect surveillance systems. For example, heart defects are the most common type of birth defect, and among those, septal defects predominate. No unusual birth defect types or clusters of birth defects have been noted. Because pregnancies where vaccination was received in the first trimester are not included in this current cohort, and because the reported number of infants with birth defects is small, these current data are not sufficient to assess an association between birth defects and COVID-19 vaccination. However, these reported birth defects by participants do indicate that our registry is identifying this important outcome and their distinct types, which is needed to address the larger question. Next slide, please. I'd like to end this portion of the vaccine safety presentation with some concluding thoughts. Next slide. From the information we've reviewed, we can see that there is accumulating data from the pregnancy registry on the safety of COVID-19 vaccination during pregnancy. Specifically, we've reviewed the currently available registry data and have found no evidence of an increase in spontaneous abortion rates and no evidence of any disproportionate negative infant birth outcomes. CDC will continue to closely monitor the safety of COVID-19 vaccination during pregnancy and will provide updates as more data become available. The pregnancy registry is continuing to enroll participants with a goal of enrolling up to 20,000 participants for each vaccine type. Next slide, please. I'd like to thank the many people who contribute to our ongoing vaccine safety monitoring work, and especially the pregnancy registry participants. Thank you.
Thank you, Dr. Olson. I'd like to open up this presentation for questions. Dr. Daly.
Yeah, thanks so much for this presentation, Dr. Olson. I'm going to make a comment and then I have a clarifying question. The comment is that I think the pandemic has taught us that sort of what we thought was impossible or hard to do is really possible. And this is an example where we have this surveillance system that's really been able to recruit and enroll women and then follow them over time. You know, we know that there's a number of difficulties of enrolling them in initial phase 3 clinical trials, but this is just really important that we have this data. We're very fortunate. The clarifying question is around slide 14, if we could go back to that. So I found this very reassuring in the sense that the sensitivity analysis was really sort of the most conservative, and even that is below the Mukherjee rate of spontaneous abortions. But could you put that Gold Harbor and Fireman in some context? Is it possible that it's just very different methods, or is it possible that spontaneous abortions have increased in the last 30 years, which I think is possible given how demographics have changed and other things? Again, I find this reassuring, but I want to understand how to interpret the Gold Harbor paper in the context of what we found here in VSafe. Thank you.
Yeah, thank you for that question. So it's interestingly, the methodologies behind the historical reports and reports over time of spontaneous abortion rates vary quite a bit, and probably more than one might have expected before sort of diving into the literature. There's considerable variability in populations reported upon, the ascertainment of and clinical diagnosis of pregnancies and how losses are identified and confirmed. And so it is a bit difficult to compare studies directly to each other, we found. So we felt it was important to kind of look at the range of these SAB reports, evaluate their methodologies, and select the ones that seemed most appropriate and similar to what we were trying to do. But there was still variation among them. We were very fortunate in that we were able to obtain the input of one of the nation's leading subject matter experts in this area, who's very intimately familiar and has contributed greatly to the methodology and the literature, who worked with us on this assessment. And you're right, the extreme case that we took was the most conservative we could have. We certainly are aware that some participants dropped out of the registry and we were unable to contact them. But they later reported, sometimes by email, that they'd had miscarriages and asked us not to contact them. So we know that does happen, and we wanted to ensure that we accounted for that. But the results still were within the bounds that we'd established based on previous literature. Thank you.
Thank you so much. Dr. Goldman?
Thank you. Excellent presentation. Really reassuring information. I'm wondering, though, a little side information to that, because a lot of my vaccine-hesitant male patients are concerned about male fertility, and there's a lot of disinformation out there. Is there any data collection along that lines, or is that something that can be looked at as we tackle the social media and disinformation that's going on regarding this issue?
Yeah, that's certainly something we're well aware of. Is a concern that has been expressed by people, and it has kind of taken off across the social media sphere. This study does not look at that at all because all of our participants are already pregnant. So we have looked at some preliminary data reported into VSafe following at the time points later in the check-in points, like at the 3 and 6 month check-in points to the VSafe after vaccination symptom tracker. And for individuals who answered the question at the 42-day mark and indicated that they were not pregnant, we've had over 20,000 positive pregnancy tests. We're very clear about that. We don't have any follow-up information on these pregnancies, but we do have over 20,000 participants in that registry, in that VSafe after symptom tracker, who have reported positive pregnancy tests beyond the point at which we asked, around the time of vaccination. So assuming these are pregnancies that occurred subsequent to vaccination. We don't have any information that I'm aware of, unless somebody else here wants to type in, about male infertility issues. That's not something that has been a part of this area of surveillance.
Thank you. Dr. Saneas?
Yes, thank you. Thank you for this excellent presentation. Given that more than 80% of participants were healthcare workers and do not reflect the general population, were there any subgroup analysis performed in the non-healthcare worker participants?
Thanks. We really haven't done that to date. As we are continuing to enroll, that proportion of healthcare workers will go down, and we're aware that the study population demographics are in the process of shifting because of the time course. We're following the pregnancies as they move along, so we're sort of the initial group that we're following were those who received vaccine when it was first available and were prioritized for vaccination. So they sort of by definition ended up being a lot of healthcare workers. But we are, taking some additional steps to try to ensure that we have a better balanced study population, in addition to the fact that just the population changed over time, the population pool from which we're drawing for interviews. Thank you.
Okay, thank you. We'll move on to the next presentation, which is Dr. Elise Carbonda from Health Partners Institute, presenting on the safety monitoring, pregnancy safety monitoring, and the vaccine safety data link.
Okay. Thank you for inviting me to present our work on the safety of COVID-19 vaccination and pregnancy from the Vaccine Safety Data Link. Next slide. As an overview, I will first present data from the VSD on receipt of COVID-19 vaccines before and during pregnancy. Then I will review data from our recently published study on spontaneous abortion following COVID-19 vaccination. And finally, I will share data from our ongoing monthly stillbirth surveillance. Next slide. The VSD is made of 9 integrated health systems working in collaboration with CDC. 8 of these health systems are data contributing sites. These sites create standardized files using data from electronic medical records, claims, and administrative databases with weekly updates. Sites also create more comprehensive data files, which include birth records. These are updated on an annual basis. Next slide. Before presenting our data, I would first like to describe the algorithms that are the critical underpinnings of our work. Previously, the VSD developed and validated the pregnancy episode algorithm, or PEA. This algorithm is applied to the VSD annual data files and is used to identify completed pregnancies. The PEA is the algorithm that we used in our prior VSD studies of maternal Tdap and maternal flu vaccine safety. Recently, an enhanced pregnancy algorithm was developed and validated, known as the Dynamic Pregnancy Algorithm, or DPA. The DPA incorporates data from the standardized VSD files with weekly updates and is used for identifying ongoing pregnancies. The DPA has made our work on the safety of COVID-19 vaccine and pregnancy possible. Next slide. Using the DPA, we are now able to track receipt of COVID-19 vaccines before and during pregnancy in the VSD in near real time. The figure shown here includes data on COVID-19 vaccines administered between December 14, 2020 and July 31, 2021. During this time, there were 122,998 pregnancies in the VSD, and on the far left, marked by the oval, there were 10,178 pregnancies in women who received at least one COVID-19 vaccine dose prior to pregnancy. The orange bar shows the 6,792 pregnancies in women who received 2 COVID-19 vaccine doses prior to pregnancy. Next slide, please. This slide is similar to the last, but now the black oval and blue bars identify women vaccinated during pregnancy. As of July 31st of this year, there have been 31,080 women in the VSD who received at least one COVID-19 vaccine dose during pregnancy and 23,310 women who received 2 doses during pregnancy. Next slide, please. Now I will transition to present data from our recently published study on spontaneous abortion following COVID-19 vaccination during pregnancy. Next slide. For this study, we first identified spontaneous abortions and ongoing pregnancies 6 to 19 weeks gestation. Spontaneous abortions were assigned to a single 4-week surveillance period. Ongoing pregnancies, including pregnancy time before a spontaneous abortion, was assigned to 1 or more surveillance periods. For these spontaneous abortion cases and ongoing pregnancy period controls, we used generalized estimating equations to calculate the odds of exposure to a COVID-19 vaccine in the 28 days prior to the spontaneous abortion, compared to the odds of exposure to a COVID-19 vaccine in the 28 days prior to an index date in the ongoing pregnancies, while adjusting for gestational age groups, maternal age groups, receipt of prenatal care, race, ethnicity, and VSD sites. Next slide. This figure shows how spontaneous abortions and ongoing pregnancies were classified across surveillance periods. Each horizontal bar represents a unique pregnancy. The yellow rectangles are ongoing pregnancy periods. The orange bars are spontaneous abortion periods. The red asterisk represents the dates of a spontaneous abortion, and the black boxes are the 28-day lookbacks for vaccination. As an example, subject number 1 at the top of the figure contributed data in surveillance period 1 as an ongoing pregnancy and did not contribute to surveillance periods 2 through 7 because the pregnancy was then beyond 20 weeks gestation. Subject 2 contributed data as an ongoing pregnancy in period 2 and as a spontaneous abortion in period 3, while subject 5 contributed data as a spontaneous abortion in period 4 who was vaccinated in the prior 28 days. Next slide. This slide shows vaccines received before 20 weeks gestation among the 105,446 pregnancies included in the cohort from December 15th, 2020 to June 28th, 2021, and stratified by ongoing pregnancy versus spontaneous abortion. Most vaccines received were the messenger RNA vaccines. Next slide. Ongoing pregnancies could contribute data to more than one surveillance period. So now we were looking at all 264,104 pregnancy periods and receipt of COVID-19 vaccines in the prior 28 days, stratified by ongoing pregnancies versus spontaneous abortions. Across all pregnancy periods in strata, 8.0% of ongoing pregnancies and 8.6% of spontaneous abortions received a COVID-19 vaccine in the prior 28 days. The rows below show these same comparisons by gestational age groups and by maternal age groups. Next slide. This slide's similar to the last, but now we were looking at receipt of COVID-19 vaccine in the prior 28 days, stratified by race, ethnicity, and by number of antenatal visits. Next slide. And this slide shows how receipt of COVID-19 vaccines in the prior 28 days changed over time, or in this case by surveillance period, with most vaccinations occurring between March and May. Next slide. In this table, we show for the full population, the adjusted odds of COVID-19 vaccination in the 28 days prior to spontaneous abortion as compared to ongoing pregnancy controls was 1.02 with a 95% confidence interval of 0.96 to 1.08. Odds ratios varied slightly when stratified by gestational age. There was no difference in the odds ratios when stratified by vaccine manufacturer. We did not calculate adjusted odds ratios for the Johnson & Johnson vaccine due to the small number of exposures. Next slide. A few limitations should be noted. First, spontaneous abortion cases were not chart confirmed and dating may be inaccurate early in pregnancy. Second, we were unable to adjust for some potential confounders, including prior pregnancy history. Nevertheless, in summary, we found that among women with spontaneous abortions, the adjusted odds of a COVID-19 vaccine exposure were not increased in the prior 28 days as compared to women with ongoing pregnancies. Next, we are planning to conduct an individually matched case control study with all spontaneous abortion cases chart confirmed. Next slide. Now I will shift gears to share updates on our monthly surveillance for stillbirths following COVID-19 vaccination. Briefly, potential stillbirths with COVID-19 vaccine exposures are identified monthly from our dynamic pregnancy algorithm. To increase sensitivity for finding stillbirths, we also identified late spontaneous abortions. All potential cases were chart reviewed by sites and then adjudicated by our Yale obstetrics team. Goals of chart review and adjudication were to confirm the outcome, to estimate the date and gestational age at fetal demise, and to identify a possible etiology for the stillbirth. For confirmed stillbirths using the adjudicated date and gestational age at fetal demise, timing of any COVID-19 vaccine exposures was then reviewed. Next slide. This slide shows our stillbirth surveillance data for the period December 2020 through July 2021. During this period, there were 11,300 live births in the VSD who received at least one COVID-19 vaccine dose during pregnancy. Focusing on the bottom row, which summarizes data for the full period, Using the dynamic pregnancy algorithm, to date, we've identified 670 possible stillbirths, and of these, 92 had a possible COVID-19 vaccine exposure during pregnancy. These 92 cases were chart reviewed and adjudicated. 66 were excluded with reasons shown on the slide. The majority were spontaneous abortions rather than stillbirths. 26 cases have been confirmed as stillbirths with one or more COVID-19 vaccines received during pregnancy. I will provide additional information on these 26 cases on the next few slides. Next slide, please. This figure shows the distribution of gestational ages for the 26 stillbirths identified in the VSD. The mean gestational age at stillbirth was 29.5 weeks with a standard deviation of 6.6 weeks and range of 20 to 40 weeks gestation. Next slide. Of the 26 stillbirths, after chart review and adjudication by the Yale obstetrics team, 25 had at least one complication associated with stillbirth. Most common among these were umbilical cord or placental complications, obstetric complications, and maternal comorbidities. Next slide. The figure on this slide shows timing between vaccination and stillbirth for the 26 cases. For the full 26 cases, stillbirths occurred between 8 and 140 days following dose 1. And for the 16 cases who received 2 vaccine doses in pregnancy, the timing between dose 2 and stillbirth ranged from 3 to 112 days. Next slide. This slide is similar to the last, but now it shows a distribution of timing between vaccination and stillbirth by manufacturer. There were 4 cases that occurred following the J&J vaccine, 17 following Moderna, and 21 following Pfizer. Next slide. Of note, the stillbirth surveillance is descriptive. There's no comparison group. In summary, monthly stillbirth surveillance with chart review and adjudication has identified 26 stillbirths following COVID-19 vaccination from December 2020 through July 2021. Nearly all cases had one or more stillbirth risk factors. No concerning patterns were identified related to the timing of vaccine exposures or stillbirth etiology. A future case control study is planned. And next slide. And finally, I'd like to thank the many people at Health Partners, Yale, Kaiser Northwest, CDC, and other VSD sites who contributed to this work.
Thank you, Dr. Carvanda, for that incredibly thoughtful presentation and for the rigorous study design. And thanks to your entire VSD team. I see Ms. Hayes has her hand up.
Yes, thank you. Carol Hayes, the American College of Nurse Midwives. Number one, I just want to say what great data this is. And then my next comment is that it's so nice to have the racial diversity that we have with VSD that we don't have in B-Safe, so that's really reassuring. And my question is, in the stillbirths that occurred with the J&J vaccine, could you please update, if you have that data, to present on what the links were and were there any clots formed to the women who received the J&J vaccine?
Thank you for the question. I don't have the exact etiology in front of me for those J&J, the stillbirths associated with J&J vaccines, but I can follow up with you.
Thank you.
Thank you. Dr. Alt?
There were data from the last pandemic that influenza vaccination actually protected against stillbirths. So sometime in the future, I would be curious to see data if COVID vaccine also protects against stillbirths. You may have seen in the news last week that public health officials in Mississippi have noticed a spike in stillbirths over the summer correlating with pregnant women getting COVID. So rather than look for negative associations, I'd certainly be interested in seeing positive associations in some future research.
Thank you. I agree.
All right, thank you very much. If there are no additional questions, I'm going to turn it over to Dr. Kip Talbot just to do a brief summary from VAST. Just give us a moment. And I'm happy to take a few questions after her presentation as well related to any of the pregnancy safety presentations.
Thank you, Dr. Lee. And whoever's pulling up the slides can go directly to slide 4. The first 3 are basically a repeat of this morning. All right, since February, VAST has initiated monthly and bi-monthly sessions with additional experts to review data on vaccine safety and pregnancy. This is especially important as pregnant women were excluded from the original vaccine studies. There have been 6 maternal immunization-focused sessions during the VAST calls to date, and we have reviewed data from VAERS, VSafe, and VSafe Pregnancy Registry, VSD special studies, and manufactured data and plans for further study. Next slide. VAST first reviewed data on vaccination of pregnant women from VSafe Pregnancy Registry, and VAERS. VAST assessments include a large number of pregnant women have chosen to receive COVID-19 vaccines in the United States. Novel Pregnancy Registry and VSafe was established to monitor pregnancy and birth outcomes. Similar to non-pregnant adults, pregnant women commonly report local and systemic reactogenicity, pain, fatigue, headache. Pregnancy and birth outcomes following COVID-19 vaccination appear similar to rates reported in the literature. Next slide. In April, May, and June, VAST reviewed data from VSD, which contributed to data from VSafe and VAERS, showing no safety concerns. Specifically, spontaneous abortion is near real-time surveillance, stillbirth surveillance, and acute event surveillance. Next slide. Maternal vaccination safety data from multiple sources are regularly reviewed in collaboration with pregnancy experts. VAST is reassured about safety and maternal immunization. More data is emerging on the risk of COVID-19 for pregnant women, which can further inform the assessment of the risk and benefit of vaccination of this population. VAST will continue to review data on maternal vaccination and update the ACIP COVID-19 vaccines work group, the ACIP Secretariat, and ACIP on a regular basis. Next slide. This slide is all the amazing people that you saw earlier today, but I would also like to point out the maternal immunization experts who have joined this group for these specific meetings to help us review this data and to ask the appropriate questions. Thank you so much.
Thank you so much, Dr. Talbot. Are there any questions from members, ex officio or liaison members? Okay, I think, Dr. Paling, go ahead.
Yeah, this is Kathy Paling. Thank you, Dr. Talbot, for a great presentation. Thank you, Dr. Olson. I'm going to go back to Dr. Olson because as I'm taking care of newborns, I'm seeing an increase in maternal infections. And the gestalt is they seem to be more severe than they were earlier in the pandemic. Is there an analysis going on about the impact of COVID infection in pregnant women in VSD?
I think I'm sorry, this is Christine Olson. I think if the question is about VSD, I'll let Dr. Carbanda take that. But I do believe, if I'm not mistaken, that Dr. Mini Dahlman will be presenting on some of the current epidemiology on pregnancy related to COVID infections, and that might be answered in what she's about to present.
Yes. Okay. Thank you. That would be it.
Yeah, I can just answer for VSD as part of our safety work. We will be looking at infant outcomes, and specifically there are some studies looking at infant infections in the first 6 months of life, but those data are yet to come.
Thank you all to all of our speakers for the review of pregnancy safety. It has been incredibly reassuring to date. Dr. Sanchez, would you like to ask one last question?
Yes, I just wanted to comment on Dr. Paling's comment as well. that just anecdotally, we've always allowed rooming in with mothers and babies, mothers who are positive at delivery, and just anecdotally, it seems that slightly more of our newborns at 24, 48 hours are testing positive, although the majority of them are asymptomatic. So I wonder if it's also transmission with the Delta variant as well.
Thank you, Dr. Sanchez. And I'm going to turn it over to Dr. Amini-Delman because I believe that the pregnancy safety data is incredibly important for us to review to, reassure that our current vaccination program makes sense. But I have to say, in the context of the data that we're seeing emerge in pregnant women, I think this particular set of data will be incredibly helpful to have Dr. Amini-Delman's presentation on the latest epidemiology in pregnancy.
Thanks so much. Good afternoon, everyone. I want to thank ACIP for inviting me to speak today and for those who presented during this session. I think the series of questions really led nicely to this presentation. So I will be providing updates on COVID-19 disease and pregnancy, including recent epidemiologic trends, vaccine effectiveness, and CDC's vaccine recommendations. Next slide, please. These are my disclaimers. Next slide, please. So I'll begin with recent trends in the epidemiology of COVID-19 among pregnant people. But before doing so, I'd like to address the terminology used in this presentation. The term pregnant people will be used as much as possible. However, for publications referencing pregnant women, I will maintain the terminology used in the original report. Next slide. This is the epidemic curve of pregnant people with laboratory-confirmed SARS-CoV-2 infection reported through the Nationally Notifiable Disease Surveillance System. And as of September 20th, 2021, 123,633 laboratory-confirmed SARS-CoV-2 infections have been reported among pregnant people. These case counts are likely an underestimate of the true number of SARS-CoV-2 infections because pregnancy status is not known for all cases reported to CDC. Several things to note on this slide. The case trend mirrors that of the non-pregnant population shown earlier today, with a clear fourth wave of infection associated with the Delta variant. The recent peak in pregnant cases began at the end of June and is higher than the spring peak in cases that we saw back in March. And more than 1,000 cases have been reported among pregnant people weekly during the month of June. Our case data does not routinely capture vaccination status. However, clinical partners have shared anecdotally that the majority of cases receiving care are unvaccinated pregnant persons. We hope to have the vaccination status of cases in the future. Please note there is a 2 to 4 week data delay, and therefore the decrease in cases that you see at the tail end should be interpreted with caution. Next slide, please. This is the most important graph I will show today. It overlays the number of ICU admissions and deaths among pregnant people on the epidemic curve. And two very concerning trends are displayed and have been highlighted in recent news reports and in some of the conversations earlier. The first is the recent increase in ICU admissions depicted in blue. While the number of pregnant people admitted to the ICU was highest early in the pandemic and subsequently declined, we now see an increased number of pregnant people admitted to the ICU in July and August. And we are hearing from clinical partners that this trend in ICU admissions is continuing through September. Second, the number of deaths among pregnant people has increased as seen in black. The deaths reported in August is the highest number of deaths reported in any month since the start of the pandemic. And while we do not have the vaccination status for pregnant persons admitted to the ICU or for those who have died at this time, we do have preliminary data from other sources suggesting that these are predominantly unvaccinated persons. For example, data in COVIDnet from 2021 indicate that approximately 97% of pregnant women hospitalized with confirmed SARS-CoV-2 infection are unvaccinated. Again, similar to case data, these data may be underestimates due to lag time in death reporting. Next slide. Increased ICU admissions and deaths is not entirely unexpected. We know that pregnancy is associated with severe COVID-19 illness, and we know that COVID-19 is associated with adverse maternal, pregnancy, and neonatal outcomes. Seen here are the forest plots from the Living Systematic Review by Eladi et al. And some additional data from a systematic review by Wei et al. In the top panel, you can see that pregnant women with COVID have a statistically significant higher odds of ICU admission, ventilation, and extracorporeal membrane oxygenation compared with non-pregnant women of reproductive age with COVID-19. In the bottom panel, you can see that pregnant women with COVID-19 have a higher risk of maternal death, preeclampsia, preterm birth, and stillbirth than pregnant women without COVID, and that neonates born to pregnant women with COVID-19 have higher risks of neonatal intensive care unit admission when compared to those born to women without COVID-19. Of note, the absolute numbers of maternal deaths and stillbirths were low, so findings should be interpreted with caution. Next slide, please. I also want to call your attention to a CDC publication that assessed the risk of severe illness among symptomatic pregnant women with COVID-19 compared to symptomatic non-pregnant women with COVID-19. Among approximately 400,000 women of reproductive age with laboratory-confirmed SARS-CoV-2 infection, approximately 5.7% were pregnant. This analysis, which adjusted for age, race, ethnicity, and underlying medical conditions, found a statistically significant increased risk of death for symptomatic pregnant women with COVID-19 compared to non-pregnant symptomatic persons with COVID. Next slide. In addition to these findings, perinatal infection is another outcome of interest for pregnancies affected by SARS-CoV-2 infection. This recent analysis examined the results of SARS-CoV-2 PCR testing among approximately 26,000 neonates. Among these, 13% of neonates underwent testing, and 4% of neonates born to women with SARS-CoV-2 infection were positive. Other cohorts have estimated perinatal infection rates at approximately 1 to 2%. So while perinatal infection among neonates appears to be a rare outcome, it is yet another outcome to consider in the risk-benefit analysis of vaccination during pregnancy. Next slide, please. Now I will present recent data on COVID-19 vaccine effectiveness in pregnancy. Next slide. There have been 2 published reports on vaccine effectiveness in pregnant people from Israel. Both assessed receipt of the Pfizer-BioNTech vaccine and matched vaccinated pregnant people 1-to-1 to unvaccinated pregnant people by demographics and clinical characteristics. Next slide. The first study is by Goldstein et al., and it examines the cumulative incidence of infection over time. This is a retrospective cohort study from a large state-mandated healthcare organization in Israel. You can see with the curve on the right the cumulative incidence of infection over time. Unvaccinated is in orange and vaccinated in blue. There were 202 SARS-CoV-2 infections in the unvaccinated group and 118 in the vaccinated group. And the authors concluded that mRNA vaccination compared with no vaccination was associated with a significantly lower risk of SARS-CoV-2 infection among pregnant people. Next slide. The second study by Dagan et al. Was an observational cohort study of pregnant women aged 16 years or older with no history of SARS-CoV-2 infection. Approximately 10,800 vaccinated pregnant women were matched 1-to-1 to unvaccinated pregnant controls. Cumulative incidence of infection curves of SARS-CoV are shown on the right. The curves in blue are those vaccinated, and the curves in red are unvaccinated. You can see these groups are similar until about day 14 post-vaccination, when the incidence of infection in the vaccinated group begins to decline. In total, there were 235 infections in the unvaccinated group compared to 131 infections in the vaccinated group. The authors estimated vaccine effectiveness after the second dose, 7 to 56 days later, was 96% for any documented infection 97% for symptomatic infection, and 89% for COVID-19 related hospitalization. Overall, the vaccine effectiveness estimate for pregnant women is not lower than that for the general population. And I believe more data are forthcoming on vaccine effectiveness during pregnancy from CDC. Next slide. In addition to examining vaccine effectiveness for preventing maternal infection, there is great interest in understanding if maternal vaccination confers immunity to the fetus or neonate. Current data from Gray et al., shown here on the left, indicate that for pregnant people who have received an mRNA COVID-19 vaccine during pregnancy, immunogenicity is similar to that observed in non-pregnant women. In addition, antibodies have been identified in umbilical cord blood and breast milk. These findings are encouraging but not unexpected. More data are needed to determine whether maternal vaccination at different points during pregnancy can provide immune protection to the neonate. And NIH is beginning a multi-site study on this topic. The details are listed here on the right. While immune protection to the neonate conferred by maternal immunization is an important area of study, we cannot lose sight of the importance of protecting pregnant persons themselves. We all know that a healthy mother is critical for a healthy pregnancy and a healthy infant. Next slide, please. For the last segment of the talk, I will review CDC's updated clinical considerations for COVID-19 vaccine in pregnancy released on August 11, 2021. Next slide. CDC has made a strong recommendation for COVID-19 vaccination in pregnancy. This recommendation, as you see on the slide, aligns with recommendations recently released from several clinical organizations, including the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, and over 20 clinical professional organizations who have signed on to indicate medical consensus. I'm going to read the recommendation. COVID-19 is recommended for all people aged 12 and older, including people who are pregnant, breastfeeding, or are trying to get pregnant now or might become pregnant in the future. Next slide. These recommendations are based on the evidence to date on the safety, effectiveness, and health benefits of vaccination. We know that pregnancy increases the risk for severe illness from COVID-19, and that COVID-19 is associated with adverse maternal, pregnancy, and neonatal outcomes. We have evidence on the safety of mRNA COVID-19 vaccines during pregnancy, and the information to date has been reassuring. We have recent studies on vaccine effectiveness demonstrating that vaccination during pregnancy reduces the risk of infection and hospitalization. We have studies that have identified vaccine antibodies in cord blood and breast milk, which are promising signs with regard to the potential for immune protection for the neonate. However, despite all this information, currently, coverage of COVID-19 vaccination among pregnant people is very low. Next slide. This graph depicts coverage of COVID-19 vaccination among pregnant people reported to CDC's vaccine safety data link described earlier. As of September 11th, only 30% of pregnant people were fully vaccinated against COVID-19 prior to and during pregnancy. The first arrow depicts when COVID-19 vaccines became widely available, and the second and third arrows show when strong recommendations for COVID-19 vaccination for all pregnant women were issued. The purple bar represents people who received both vaccine doses during pregnancy. The orange represents those vaccinated before and during pregnancy, and the light blue bar shows the number of pregnant people vaccinated prior to pregnancy. While the overall trend in vaccination is upward, vaccination coverage both before and during pregnancy is far lower than we hope to achieve. These low coverage rates are particularly concerning in light of the recent increases in cases, ICU admissions, and deaths among pregnant people. Next slide, please. CDC and our clinical partners are committed to improving vaccine coverage for pregnant people, including encouraging vaccination prior to, during, and after pregnancy. Just to highlight a few concrete efforts. We are assessing the reasons for vaccine hesitancy and planning to share personal stories of families. One of the most common reasons for vaccine hesitancy is concern about safety and theoretical risks of the vaccines. As you can see from our presentations today, we are making every effort to disseminate information rapidly and broadly here at ACIP, on our website, through social media, and through our partners. We continue to address vaccine access issues, and we're working with clinical partners to encourage more clinicians caring for women to become vaccine providers. We are continuing to develop and provide resources to assist healthcare providers and others who are having conversations with pregnant people about vaccines. And finally, we are working closely with clinical and public health partners to ensure consistent messaging about the need for COVID-19 vaccination and to dispel myths. Next slide. I'd like to extend my sincere thanks to the following groups of people listed on the slide who have worked tirelessly on COVID-19 and pregnancy. And finally, taking off my CDC hat and putting on my clinical OBGYN hat, I want to speak directly to the public listening today. We know that pregnant people with COVID-19 can become very sick. Some will die, and many will experience pregnancy and neonatal complications. We know that because of COVID, some children will grow up without their mothers. We know that COVID-19 vaccines are safe and effective. If you are pregnant, postpartum, breastfeeding, trying to get pregnant now, or might become pregnant in the future, please get vaccinated. Happy to take questions.
Thank you, Dr. Meany-Delman. This presentation is now open for questions. Dr. Alt.
You didn't show the vaccine uptake rates among different ethnic groups, and when I looked at it a week or two ago in our Black communities, it's about half of what you showed, I think, on your graph. So we definitely need some specific outlook to a group that suffers from very high maternal mortality and morbidity anyway as a baseline, specifically for some groups of pregnant women that are under-vaccinated.
Thanks, Dr. Alt. So the highest uptake observed among pregnant people was among those who are Asian, non-Hispanic at 35.7%. The lowest uptake was observed among Black, non-Hispanic at 13.5%. And among non-Hispanic whites, it was 27.2%, and Hispanic, 21%. Thank you for drawing my attention to that. And I did want to comment back to a question earlier about Delta. I think we're all interested in whether Delta variant is associated with more severe disease in pregnancy. The only data I am aware of is data from the United Kingdom, which doesn't have genomic sequencing. It's basically a time series. So I think the question still remains whether the Delta variant is associated with more severe illness or higher rates of perinatal infections. Right now, I think the message is we absolutely have to encourage people to get vaccinated.
Thank you. Dr. Cotton.
Thank you. I have a question for perhaps all of the pregnancy-related speakers, but in general, for VSD and for the VSafe registry, Black women were underrepresented. Are there any plans to try to enhance that given how much the community has been impacted?
This is Christine Olson. I can answer that for the pregnancy registry, and then others can certainly chime in. We recognize that is a deficiency of the current population pool that we're able to present data on for the pregnancy registry, and we are we do have active plans to try to prioritize some groups who are significantly underrepresented by the nature of how people enrolled and became participants in VSafe. So we certainly are well aware of that and taking efforts to address that.
Yeah, and this is Elise. I can comment. For VSD, our data is based on members of our integrated health systems. The VSD as a whole has worked to increase diversity in the population, and it added Denver Health as a VSD site, and there's other sites that may be joining that would increase diversity, but their data is yet to be included in our work.
Thank you very much. That's good to hear.
Thank you. Dr. Sanchez.
Thank you, Dr. Lee. No, that was really a very enlightening presentation. I really can't agree with you more. A couple comments. Your adverse outcomes such as stillbirth, I mean, that has remained still somewhat controversial in terms of the relationship, and maybe Dr. Alt could comment on, because some of the studies have not shown that association in pregnant women with COVID-19 infection. But so it was interesting, your slide, I believe it's slide 6, that showed the associations with adverse outcomes. Some of that up to now anyway has been somewhat back and forth. I will say though that if the data continue to show like this, would you be including, if we do come up, and I hate to, if we come up with a booster dose for so-called high-risk individuals, would you consider pregnant women such in that category?
Thank you, Dr. Sanchez. I appreciate your comments about stillbirth. So I do think the numbers are small here. We did look at the studies that were included in the ALADI systematic review. And to be honest, those studies are from, many of those studies are from countries that have much better stillbirth surveillance than we have in the United States, quite frankly. So I think you're right. It's still a question that remains. But I think the studies that were done in countries that have better stillbirth surveillance are interesting, albeit small numbers. So I think the question still remains, but I think we're concerned. And Elise maybe has some data that she can talk about from VSD from some of the early work when I'm finished. The other comment about boosters, I don't see a clear and compelling reason for this to be different than it is for the primary vaccine series, but I think we have to see what ACIP recommends. At this point, I think it's premature to come up with any specific recommendations for pregnant women.
Thank you. Dr. Carbonta, I don't know if you wanted to add anything.
Yeah, I mean, I can just add that in the VSD early in the pandemic, we published some data on COVID infection and in pregnant women and outcomes. And it was published in the MMWR. And I think we were able to look at one of the issues that's been discussed, whether it was women admitted and found to, maybe admitted for delivery and found to have COVID infection versus women who were sort of symptomatic. And in that very small sample, we found the proportion of women with stillbirths was higher than our VSD background rate. The VSD is now again looking at sort of continuing that surveillance, and that data is being collected right now. I do think it's important to be careful in these evaluations during pregnancy of understanding the right comparison group, because some of these systems, these observational systems are really missing COVID infections that are asymptomatic during the course of pregnancy. And they're really sort of capturing very well the more severe infections. And so I think the data is evolving, and we'll continue to learn from the data.
Thank you. Dr. Paling.
Thank you. I actually was reviewing and thinking back on the same tape, or on the same slide that Dr. Sanchez has had, and I wanted to reiterate the point that I think you made, in that COVID infection during pregnancy is associated with increased negative maternal outcomes, ICU admission, maternal death, stillbirth, increased NICU admissions for the newborn, increased prematurity, and increased preeclampsia. And then I think the data from that we showed previously, that vaccine does not increase any of these outcomes. And as Dr. Alt had said, there's data from influenza to say it actually may reduce it. So that will be following. And I think that highlights the importance of equitable access to the COVID vaccine and encouraging persons who have increased risk for these negative outcomes and making sure we capture everybody. Over. Thank you.
Thank you, Dr. Paling. Dr. Sanchez.
Yes, thank you, Dr. Lee. I just had another addition to that. I absolutely, I think that the data that you have presented is really important and concerning. But I also want to add that some of the consequences of prematurity may actually be unrelated to the infant infection, whether it's fetal or perinatal acquisition. And even the inflammatory changes that occur secondary to a COVID infection, whether that's asymptomatic or symptomatic, may result in placental inflammation and fetal inflammation and prematurity, leading to such adverse consequences as necrotizing enterocolitis, as retinopathy prematurity, as BPD as well. So I think those are other outcomes beyond some of the pregnancy outcomes that should also be evaluated. Thank you.
Thanks, Dr. Sanchez. I completely agree with you. I think the other thing we have to keep in mind is, if moms are really sick, sometimes delivering them is what's necessary to improve the ability to treat them. So I think there is an element of iatrogenic preterm birth as well. And I think that's another important point to make. Thanks.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a mom who hopes to be a grandmother very soon, not immediately though. I'm very disappointed by the 30% uptake of the vaccine by pregnant women, and dispelling the myth that COVID vaccines are related to infertility has been one of the major challenges I've had in trying to overcome vaccine hesitancy. There's so many women or so many people that don't understand that these vaccines actually protect mom during pregnancy. I greatly appreciate the outreach and the consistent messaging that you're talking about. And I also think that the strong recommendation from CDC and ACOG, the Society of Maternal Fetal Medicine, and the other medical organizations has been very powerful. And many thanks to all those groups. Would you also repeat the ethnic numbers, the differences in the ethnic groups? Because I missed that. You went over them so quickly, and they're so important.
Sure, I'm happy to. So first, thanks so much for your comments on the consistent messaging. I think it is incredibly important that we continue to do that. Just to address the myths, infertility is defined as a year of trying to get pregnant and not successfully getting pregnant. So I think it is hard to dispel that myth when we haven't had quite the amount of time to do longitudinal studies on fertility. But we know that, and I think Dr. Olson said this earlier, we know that many women have gotten pregnant subsequent to vaccination. And that's, like much of our data, that's the early data that we have. But I agree, it's been really challenging. There isn't a biologically plausible reason why we would expect there to be a fertility concern associated with these vaccines, and yet I agree with you, it has taken off. And can I just ask, were you interested in the vaccine coverage distribution by race and ethnicity? Is that what you were asking? Just to confirm. Okay.
Yes, you went through them quickly, and I didn't get a chance to write them down. Thank
you.
Sure,
no problem. And this is on our website, but yes, I'm happy to mention the highest uptake was observed among pregnant people who are Asian non-Hispanic at 35.7%, and the lowest uptake was observed among Black non-Hispanic persons at 13.5%. Non-Hispanic whites, 27.2%, and Hispanic persons, 21%.
Thank you.
Okay, thank you. Dr. Paling.
as I've been thinking about this presentation, your slide showing me the timing of when people were vaccinated among those who were pregnant, some getting vaccinated before pregnancy and some during pregnancy. You see in that slide that over time, an increasing number of people have received vaccine before pregnancy. And so I just wanted to highlight that point because I think we all have a role. This is not just for the OBGYNs, and that an effort to increase equitable distribution of vaccine will have a huge impact. And I just wanted to make that point. Thank you.
Thank you, Dr. Paling, for making that excellent point. I am going to ask my colleagues if there's any additional urgent business prior to adjourning today's meeting, since we are about 25 minutes over. I don't hear any objections in the room and none online. So I want to thank all of our speakers today. Today was an incredible session, packed full of information. And we are looking forward to additional conversations very soon. But are there any? Oh, okay, hold on. One comment from Dr. Cohn.
No, I just want to make sure everyone's clear about the timing for tomorrow. If there is an FDA authorization by noon tomorrow, we will be holding the meeting as scheduled. Look on the ACIP website. If you don't hear in the news about an ACIP authorization, just check and see if we've rescheduled. Oh, sorry, FDA authorization. Just check the website to see if we've rescheduled tomorrow afternoon. Thank you.
Terrific. Thank you for that clarification. And hearing no additional objections, I will now adjourn today's ACIP meeting. Thank you, everyone, for your time today. Take care.